This is a study of dual HER2 targeting in the neoadjuvant setting where patients received either Paclitaxel with Herceptin. There was another arm of Paclitaxel with lapatinib, and then a third arm of Paclitaxel with Herceptin and lapatinib. And the overall clinical result was that the dual HER2 targeting seemed to improve the pathologic complete response rate by about 10% when we look at all patients overall. And that was not statistically significant because we powered the study for a 20% difference, but nonetheless I think there were some biologically interesting trends, and the trend that we saw fits with previous neoadjuvant studies that were similar and performed in Europe. In the presentation today, Lisa will be presenting some of the genomic findings, where on this set of about 300 samples, we performed RNA sequencing to do gene expression profiling and then evaluate a number of different genomic signatures as potential predictors of PCR and or predictors of response to adding lapatinib to Trastuzumab. And I think the overall very interesting finding was that there were a number of different genomic signatures that were significant predictors of an increased likelihood of having a PCR. The first of these was what most people now know as our intrinsic subtypes of breast cancer. In particular, what we call the HER2-enriched subtype had very high PCR rates. It was actually about 70% in the Paclitaxel Trastuzumab arm, and it was almost 80% in the dual targeting arm. And then the PCR rate in almost all the other subtypes, luminal A, luminal B, there were a few basals in there, was almost half the PCR rate that we saw in the HER2 enriched. I think it was somewhere in the 30 to 40% range. So knowing your subtype was a huge predictor of differences in PCR.